Dr. Sachin Kandagatla, presenting a case report on dorsal compressive myelopathy secondary to spinal epidural angiolipoma. Spinal epidural angiolipomatosis is a atypical benign tumor of the adipose tissue with abnormal vasculature that causes spinal cord compression. They usually account for 0.14% of all spinal axis tumors. They usually arise in the epidural space and, unlike lipomas, do not exhibit age or sex bias. The symptoms of spinal angiolipomas usually appear gradually because of the progressive compression of the cord. These patients present with back pain, unstable gait, paraparesis, and paresthesias of lower limbs. Sometimes symptoms can rise rapidly because of intratumor hemorrhage and venous thrombosis. Most spinal epidural angiolipomas have a good prognosis after surgical resection. Epidural angiolipomas can occur in female more than males and usually occur in the age group of 40 to 50 years. MRI is an important diagnostic tool for detecting and characterizing spinal angiolipomas. Angiolipomas are ultimately diagnosed by histopathological examination of the removed lesion following surgery. A 30-year-old woman presented with progressive weakness of lower extremities evolving since 6 months with onset of urinary incontinence. There was no history of corticosteroids or hormonal therapy. There was no history of any trauma. On examination, she was spastic with motor grade 3 and a sensory level of D2. CT and MRI scans were suggestive of intracanal space occupying lesion located in the posterior epidural space extending from T2 to T9, showing hyperintense fatty tissue on both T1 and T2 sequences, which were trabeculated by vascular elements. Preoperative MRI showing angiolipoma lesion in the T1 weighted image. She underwent total resection of the tumor after total laminectomy from the T2 to T9 level. Microscopically, the reddish soft tissue mass was easily cleavable from the durameter. Histopathology revealed mesenchymal proliferation made of mature benign adipose cells associated with a network of small vessels, and the findings were suggestive of angiolipoma. Post-operatively, the patient neurology improved by grade 1 with reduced spasticity and early improvement in the bladder function. The histopathology slide shows angiolipoma. There was significant improvement in the VAS and ODI scores at 6 months follow-up. No early or delayed complications was noted. Histopathology was suggestive of angiolipoma. There was no evidence of clinico-radiological recurrence was seen in the latest follow-up. Conclusion: spinal epidural angiolipoma is a rare cause of progressive spinal cord compression. MRI is necessary for diagnosis, and the treatment consists of complete excision of the lesion, which results in excellent prognosis. The patient should be regularly followed up so that the recurrence can be detected early and can be managed accordingly. Thank you.